Started then. So generally, exam two is I think I like that your guys' breakdown. It's like 50% neuro and then 50% other things. The 50% other things tends to be behavior, right? This is the more behavior heavy sort of test. Um, but it's not that bad. Um, so we'll go through. I think I'll go through the neuro stuff first. But as always, Dr. Koala does a really good job of breaking down everything you need to know. I think I hit everything on here, but you definitely should by now know, or at least be familiar with all of these terms. Um, Obviously, he can't test you on all of them, but I've definitely seen questions on basically everything on this page, um, whether it is on the block exams or on comp exams or on. So just a real quick reminder, this is super, super important to understand this. The vestibular system. The vestibular system accommodates for movement of our head so that when our body moves around, our eyes can stay fixed at a point in space. This prevents us from getting motion sick. This allows us to run. You don't really realize how much your body is actually swaying as you're running forward because your eyes are doing your brain's doing a really good job of keeping your eyes semi-fixed in space. Um, so basically, how this works is as I turn my head to the left, the vestibular system recognizes that my head is turning to the left, and then it forces my eyes to the right. Now, if there's a problem with the vestibular system itself, if one of the ears, one of the canals is damaged, either the canal itself or the nerves going to the processing centers in the brain, um, you can have a decrease in firing on that side. And the body interprets that as though you are turning your head, and then your eye, it will start to adjust your eyes, even though your head is not moving. In response to your eyes slowly adjusting to one side, your visual processing centers will then recognize that your eyes are moving when they shouldn't be, and it will attempt to recorrect towards the middle, and that is how you get into nystagmus. So the slow component of the pathological nystagmus, with the direction the eyes move, this will be towards the side where there's decreased firing. So if I damage my right ear or pathway, my eyes will drift to the right. However, the nystagmus is named after the saccade, which is the quick correction back towards the middle. So my eyes will shoot back to the left, back towards center. I will have a leftward nystagmus. Another way to think about this is that because the saccade portion comes from the correction that is interpreted by your visual processing centers. The vestibular system itself is responsible for the slow movement, whereas the visual processing is responsible for the quick movement. So, oops, that's definitely out of order. When you talk about this, the vestibular ocular reflex test in a person who is unconscious, right? When you rotate their head, their eyes should move and then drift back towards the center. They'll move because your vestibular system is still intact. It's still trying to adjust, but you don't have any nystagmus because they're unconscious, so they're not processing visual sensation. If their eyes remain fixed in space, then it means you're not getting that slow movement. So it means the vestibular ocular reflex and the vestibular pathway is destroyed, which means you have brainstem damage usually, especially if it's bilateral, right? And then the other way they test this, right? So they test this in unconscious patients. This is the caloric testing, right? So when you turn your head, one based on the direction that the endolymph flows, one of the neurosensory processing centers is going to increase its firing, and one of them is going to decrease its firing, right? So if I turn my head to the left, my eyes need to adjust to the right. If I turn my head to the left, the right side is going to decrease in firing. The left side is going to increase in firing. If you add warm water or cold water, you can get the same effect. Cold water will decrease the firing of that neuron. Warm water will increase the firing of that side. So putting warm water in my left ear is the same thing as turning my head to the left. The way that I like to think about this is whichever ear you would put cold water in, you're kind of like your eyes are looking, right? Like if you get splashed in the face with cold water, the first thing you're kind of going to do is you're going to like look over, right? You're going to like give side eye to see where the water's coming from, right? So that's how I remember which way the slow direction is, and then the fast is just in the other direction. But this is important because when you start talking about when the questions actually ask you, they're going to talk about basically what would happen in an unconscious patient, what would happen in an unconscious patient with brainstem damage, etc. So in a normal patient with their eyes open in physiological circumstances, when you put the water in, the eyes will slowly move to one side and you'll get a nystagmus back. That is normal conditions. If the person is unconscious, you will get the slow drift, but you will not have a nystagmus because they are not visually processing. And then if nothing happens, then you know that the vestibular-ocular system is destroyed, and you have a brainstem lesion. Now, if you remember, you have the intranuclear ophthalmoplegia, or MLF syndrome, right? So that's how you can get a unilateral loss of this slow movement, because you're basically not communicating with the other eye. And I'll briefly run back over that. But real quick, so the TLDR on this is the vestibular system is responsible for the slow movement. Oh, man. The vestibular system is responsible for the slow movement, and the visual processing is responsible for the nystagmus. And then you can just remember the caloric testing, right? The cows, cold opposite, warm same, which is the direction, describing the direction of the nystagmus, which is named for the saccade. I know I've beaten this to death, but it's kind of confusing sometimes for a lot of people, and you will 1000% be tested on this in multiple different ways. But back to this one. I don't remember when you guys learned this, but I'm assuming you have to know this by now because you're taking these second exams, so you have to know everything in BAB, right? A lot of times they'll ask you about dizziness. Clinically, dizziness is obnoxious to try to diagnose, especially in old people, because not everybody's definition of dizziness is the same. And there's a billion and six things that can cause it. And especially like, orthostatic hypotension is probably actually the number one cause of like quote unquote dizziness, right? But on these exams, BPPV, benign positional vertigo, paroxysmal positional vertigo, this is the dislodgement of the otolith, right? And this will be dizziness triggered by head movement. And this, if you do the Dix-Hallpike maneuver, which is where you put the head at like 45 degrees, tilt them back, they'll get a nystagmus. It is very important that you know the names of the Dix-Hallpike maneuver and the Epley maneuver. The Dix-Hallpike maneuver is how you diagnose nystagmus. The Epley maneuver is where you kind of shuffle their head around and try to put the otolith back where it belongs. It's a non-surgical thing you can just do in your clinic, and hopefully it fixes EPV. The important thing with this is you don't have anything like you don't have any tinnitus, you don't have any hearing loss, you don't have any pain. It is just dizziness brought on by head movement. Meniere's disease, this is increased pressure in the inner ear. There's this classic triad of vertigo, unilateral hearing loss, and unilateral tinnitus, which can both come in and out. The big key to this will simply be that they just have these three. They have these three. The question stem doesn't tell you anything about, it doesn't tell you anything about like sick illnesses. Maybe this is the first time they've had it, right? It's going to be Meniere's disease. Vestibular neuritis, they'll tell you that the patient had like some general upper respiratory viral infection usually. This is an acute episode that goes away quickly, completely resolves. If it completely resolves quickly, especially after an illness, it was just vestibular neuritis. That's just agitation of the vestibular nerve, right? Migraines can cause similar symptoms. They're not going to ask you about that. Acoustic neuromas, also known as vestibular schwannomas. They ask about this continuously all of the time. This will guarantee be on probably this test and also your final and also probably your comfort exam and also probably STEP. Like everything else in the brain, this is caused by mass effect. You have these neuromas that grow and they impinge on the vestibular nerve and it causes dizziness, right? If you see a question stem that shows you, sometimes they'll just show you at the, I think it's like the cerebellopontine angles, like where it is, right? That's the term. It's where like cranial nerve 8 comes out. If you have bilateral acoustic neuromas, it is automatically, you can assume the patient has NF2 and neurofibromatosis type 2. You have bilateral vestibular schwannomas, either they tell you in the stem or you can see it on a scan, you can assume that the patient has neurofibromatosis type 2. And then brainstem or cerebellar strokes or dizziness, very unlikely to be tested like that. If they're going to give you a stroke, there's going to be a bunch of other symptoms. But hypothetically speaking, it'll be persistent vertigo that just came out of nowhere and won't go away. But they will almost always have other accompanying neurological symptoms. So you guys should. Okay, right. Back to MLF syndrome. It's also super important. Guarantee you'll have a question on this. Quick reminder: the general pathway for how your eyes actually move is your frontal eye field of your motor cortex projected down to the PPRF. The PPRF tells the abducens nucleus, I want to move, right? So if I want to look to the left, the right side of my brain crosses over, tells the left PPRF, hey, you need to move the left eye outward. You need to abduct it. So the abducens nucleus tells the lateral rectus muscle to abduct the left eye. It also tells the cranial nerve 3 nucleus, the oculomotor nucleus, to adduct the right eye, contracting the medial rectus, moving the eye to the left. Your brain tells your left eye to move, and your left eye tells your right eye to move. I know that sounds weird, but that is technically how this works. When we want to look to the left, our brain tells our left eye to look outwards, and then the left eye tells the right eye to also look to the left. If you destroy the MLF, the right eye will not move. Now you have a left eye that is looking to the side with a right eye looking forwards, so you will get a rightward nystagmus. The left eye will saccade back to middle to try to match the right eye that is not adducting. Sorry about that. I don't know. Can everybody hear? Can somebody hear me now?
Yes.
All right, excellent, cool. You can see the screen, yes?
It's just you frozen.
Oh, it's me frozen? It's not sharing anymore?
No.
Oh, no.
Same.
Yeah, we can't see the PowerPoints for you.
Very fresh. Did you see it before?
Yeah.
Right. I'll try reconnecting. Can you see me now?
Yeah, we can.
See the PowerPoint now?
Yes.
Sorry about that. But yeah, brain tells your left eye to move out, right eye follows it. If the lesion is in the medial longitudinal fasciculus, given nystagmus towards it. If the lesion is in the PPRF, your eyes just don't move, right? Because it doesn't get the first signal, so the left eye and the right eye both don't get the signal. Know the names of these muscles. I've seen questions that just ask you. It'll ask you about this whole system, and then the actual answer will be like failure of the lateral rectus muscle to contract, or failure of the medial rectus muscle to contract will be an answer. And they'll also throw in like the muscles. They'll throw in all the other eye muscles, orbital muscles, and they'll try to do that to contract. But right, here's all the permutations of this. We went over this pretty extensively before. If anybody has any questions about this, please feel free to ask. Vertical gaze. So this is normally in kids, right? This is when your vertical gaze center is normally compressed. They can't look up. This is right in the midbrain. This is the location of this is the reason why in locked-in syndrome you can still look up and you can only look up. So with kids, you'll get the sun setting sign where their eyes are just kind of because they can only look vertically. That's why obstructive hydrocephalus, it's almost always like a pinealoma or something. It's called Paranod syndrome. I actually think they usually refer to it as Paranod syndrome. It's one of the few things that hasn't been like scientificated. I know they're trying to get rid of all the actual like names of things, but they do refer to this as Paranod syndrome more than they do vertical gaze palsy. Trochlear nerve palsy. This one's a bit annoying, but they definitely ask questions specifically about which direction the patient's going to turn their head. As dumb as that may sound, but I've definitely seen questions on this. So trochlear nerve palsy. Nerve 4 is the only nerve that comes out, the top back. So it gets stretched a lot, right? So you talk about like pseudotumor cerebri or idiopathic intracranial hypertension, where you get like kind of like swelling or like extension injuries or something. It can get stretched, it can get damaged. So their oblique muscles paralyzed, so the eye goes up and out, so they have to tilt their head to be away from the direction the eye is facing, so that their eyes can both look straight ahead. There's a refraction. I'm gonna if I go too fast or anything, please just raise your hand and stop me, or like shoot me a private message on the side if you don't want to do it publicly. And be like, hey, can you explain that again? But there's just a lot of stuff, and I don't want to waste your guys' time sending you an exam in 2 days. They will ask you a question about this. The question will almost certainly be, do you fix the problem with a convex lens or a concave lens? They could refer to it as a converging lens or a diverging lens. Just know that you give old people converging lenses because, and this is kind of the other important part that they might ask you about, you need to pull the image forward towards the retina. They might ask you, does the image fall behind or in front of the retina in like the patient that they're describing? And then for a converging or a converging or diverging lens, keep messing up, we'll push the image back. Glaucoma, this is super high yield. If you see optic cupping, you know they're talking about glaucoma. You have the two different types. You have open angle and closed angle. They ask about closed angle more. The reason they ask about closed angle more is because it's less common. So they test on it more. But it's also, this is an emergency. This happens slowly over time. This can happen quickly, and it's also iatrogenic. We cause it, right? So anything that's iatrogenic, we need to know about. Anything that happens rapidly and needs to be acutely treated, we learn about, right? They like to test about. Um, this they can both be caused by obstructed flow or obstructed flow. However, open angle is also caused by increased production of the vitreous, whereas or the aqueous, whereas closed angle is only obstruction, right? And it's rapid obstruction. You will have no pain and no redness of the eye in open angle. That's really important. For acute angle, you will have pain. If they say pain, it is not open angle. If there is pain, it is not open angle. You normally would use the actual pressure itself for like the indication as to how bad it is. But regardless of what the actual pressure is, if there is pain, it is not open angle glaucoma. I cannot say that enough times. Generally, when they ask questions about this, it's going to be about the farm. To be honest with you, this is one of the topics in these exams they like to ask about the farm. Because there's a lot of really specific things that they can ask about, such as like which drugs decrease the UV flow versus which drugs, or I mean, increase the UV flow versus which drugs decrease the trabecular flow. And then also giving anything that will dilate the pupil because it causes constriction of the radiating muscle fibers, right? And then it blocks the outflow of the aqueous humor. Macular degeneration. A lot of times you'll have drusen deposits, super duper high yield. You need to know this, 110%. I think if I was to stratify out how many questions I've seen on macular degeneration in my time in medical school, half of them, the answer has been drusen deposits. The other thing I like to ask about a lot is wet macular degeneration. I don't know, maybe 10 years ago, if you had this, you were just going to go blind. Now they give VEGF inhibitors, they'll give injections, and that stops the neovascularization, which actually helps slow the progression of the disease, and it can actually prevent the people from going blind. They ask about this a lot. Know that you inhibit VEGF to treat wet macular degeneration. Know that overexpression of VEGF can cause wet macular degeneration. The other little aside about VEGF is I didn't put this in. I did the same thing last time. I keep forgetting to put this in, but it is relevant, I promise you. If you have a premature newborn with ARDS, you give them supplemental oxygen. Premature newborns are born before normal vascularization of the retina takes place in development. So what happens is the preemies, when they're in the NICU, right, their eyes are still developing, but you're giving them 100% oxygen, or maybe not 100% oxygen, but you're giving them high flow oxygen. No, it is 100% what I'm saying. You're giving them oxygen. So their body decreases the expression of VEGF because there's a higher level of oxygen in the blood. Because it decreases the expression of VEGF, the retina is never properly vascularized, and it can cause vision problems in premature infants. It is important to know that. Retinal detachment, this happens because as you get old, the vitreous constricts, right? Or not constricts, but it consolidates, it dries out, right? And it starts to pull on the inside of the retina, get detached. They'll have basically wherever the retina has pulled away from the underlying photosensitive region, you will get blindness. So it'll be like a curtain, but it is not the curtain that they talk about, like Amaros Fugax, like the blindness coming across. But yeah, this will be usually like on one side. It'll be in one part of their field of view. If you don't ask the person to cover one of their eyes, they might not really notice because there might be overlap in their visual fields. This is also painless. I've never seen a question about it at AUC, but Amboss had a couple questions about treating it. Believe it or not, you put you put nitrogen bubbles in their eyes, and then you have them lay down for weeks, and then the nitrogen bubbles float in their eye, and it pushes the retina back up to against the back of the eye, and then it heals. You can also do cryoablation to kind of like stick it back there, and then I think they'll do it in like combination with the nitro to fix this. Your ganglion cells, super high yield, guarantee you'll have probably. I would bet you'll have 2 questions on this on Thursday. please God, understand and know. M for motion. If you understand M for motion and you have any idea what these do or how these generally work, you can figure all the other things out, right? So we detect motion primarily with our peripheral vision. Why? Because we need to know if we're going to get attacked by a lion, right? Evolutionarily, peripheral vision detects motion. Things in the center of our view is where we resolve fine detail and colors, right? So because of that, we need the bigger ganglion cells that spread out more and have wider fields to capture more information at once. These are also the ones that are primarily innervated by rods. Oh, I still didn't fix this. Oh, that's funny. I literally copied this on my slide and I still didn't fix these. But anyways, you're primarily rods and you'll have fast impulse conduction. I'm going to say this again. M ganglion cells conduct fast. They conduct quicker than P ganglion cells. This is very important. I have no idea why this might be very important for you guys for the next 48 hours, but I'm just going to say it's very important that you understand that these are fast and they detect motion. Bigger cells, larger receptive fields. P ganglion cells are in the center of the retina. Why are they in the center? Because they need to detect fine resolutions. Because of that, there's a lot of them. If you want, I think P for pixels, right? Because this is basically the resolving power of the eye. More pixels on a screen, the better the image, right? These are smaller. Parvo, cellular. Parvo literally means small or little or whatever, something in Latin. P for perception, however you want to remember it. We use, this is so important. I guarantee you'll have questions on this. I guarantee you'll have questions on this. So just please, we use the M cells in our peripheral vision to detect motion. They are fast impulses. We resolve fine details with the P cells, which are in the middle. The P ganglion cells, which are in the center of the retina. P for perception. If you take your time to figure out what you're looking at, you set red flags when something is approaching you from the side. Whether you think you see a spider and you jump back and then you realize it's just a piece of dragon. I cannot hammer this home enough. I guarantee you'll have at least 2 questions on this. Please, please, please. Please get this correct. Visual pathway lesions. I highly recommend you draw this out. And by highly recommend you draw this out, I mean I highly recommend you draw this out. Please, when you sit down on the exam, do one of these. Right? At least that. At least give yourself that. Because everything from here, like you could, I mean, this is whatever, right? Like you still have to memorize which one's which, but at least give yourself this. Because when they're describing the lesions, listen, man, if some of you guys flashcarded what left hominidis hemianopia like is and correlates to, sure, fine, that's fine. But it's so much better if you can just draw this out. Remember that the image on your eye is flipped and reversed. It is flipped left and right, and it is also upside down. So the middle field of your vision projects to the lateral portion of your retina, right? So then it comes in and it does not cross the optic chiasm. The lateral portions of your vision, the temporal portions, project to the nasal side of your retina, and they do cross. So if you have a problem with the optic chiasm, you're going to lose your peripheral vision on the outside. If you have impingement upon the sides of it, right, usually through an internal carotid artery aneurysm or something, right, or mass effect from something, you're going to need to lose part of your center field of vision. If it's unilateral, which it usually is, the fields overlap, so that's why sometimes it might not be really obvious to the patient until you have them cover their eyes. And then it splits off, right? You have the Myers loop, and then you just have the I forgot what the other one's called. Do I have it here? Oop. You have Myers loop, and the other one has a name, but they don't ever ask you the other name. The Myers loop is the one that usually gets hit on. But it's also really important to know that the Myers loop is goes down, right? Your parietal lobe, it goes down. So it's responsible for the top of your field of vision, and the radiating fibers go up. I mean, they don't really specifically go up, but they're the higher ones, so they're responsible for the bottom. So everything that gradient is flipped. The other thing I like to point out is if you look here and you follow this, and you look here and you follow this, these are both the right side of your field of view here, right? So if you have bitemporal or binasal anything, it has to happen before the lateral geniculate nucleus, right? If you have half of your field of view is gone, it has to happen before this. If you have an entire eye gone, it has to happen before this cross, right? So even if you don't remember the specific details, you should at least be able to generally localize where these are. Yeah, that's all I got. Oh, and then don't forget, if you see macular sparing, the problem is in the visual cortex occipital lobe itself. Oh, okay, so here it is. Sorry, this is wildly out of position, but guarantee you'll be asked questions about this. Don't forget, in acute angle glaucoma, you have to do surgery. They want you to know that you always do surgery. However, until you can get the person in surgery, you hit them with everything. Throw the kitchen sink at them. You give them every class of treatable drug, acetazolamide, a topical beta blocker, and pilocarpine. Dr. Paul, as always, is just the absolute best for this. Know this for sure, the categories. Know which ones increase drainage and which ones decrease production. For prostaglandins, make sure you know that they're the ones that increase UV outflow. And for the muscarinic agonists, make sure you know that they increase trabecular outflow. They don't do these. This is only this is really for acute angle glaucoma. Definitely no beta blockers, no caution in asthma. I think this is a little silly because timolol is an eye drop, specifically it's the eye drop. I mean, I'm sure you absorb some of it, but I don't know how much of a problem this actually is in practice, but they've definitely asked questions about it. More important ADR, carbonic anhydrase inhibitors. Basically, anytime they're asking a question about this, I don't know if I hammered it home hard enough last time. They're asking about the ADRs. You have metabolic acidosis, and carbonic anhydrase also resembles a sulfa drug, so it could trigger sulfa drug allergies. This is basically acute glaucoma. Acute glaucoma is basically the only time that they'll ever actually give in a carbonic anhydrase inhibitor because it messes with too many other things in your body. Also, know the increased eyelashes with prostaglandins. I've never seen a question that talks about the patient being on a prostaglandin and then asks what the side effect is, and they'll have increased eyelashes density. However, I have definitely seen a question where they'll talk about they were taking something for their glaucoma, and it was increasing the thickness of their eyelashes, or however they want to explain it. And then the answer they were looking for was increases uveoscleral outflow. So definitely know this. To the thalamic and the hypothalamic nuclei, you just gotta know the tables. These ones are the ones you really need to know specifically what they do. For the motor nuclei, just know that the ventral, if it's not the VPL or the VPM, all the ventrals work with the basal ganglia and the cerebellum. They're all motor nuclei. They all have to do with planning movement. So if you have any damage of a text or something like that, I've never ever seen a question that has asked you to distinguish between the ventrolateral and the ventroanterior and the ventrointermedial motor nuclei. I have seen a lot of questions that want you to pick one of the three of these compared to all of these when talking about motor functions. So while they won't give you a VL or a VA both as answer choices that I've seen, they will certainly give you VPL, VPM, and VL, looking for VL as the answer. VPL This is sensation for the body, right? Legs, body. That's how I remember that. BPM, M for mouth. This is your head. This is your body. Medial geniculate versus lateral geniculate nucleus. Lateral geniculate nucleus. I remember these because, like everything else with the brain, they're opposite. Your eyes are in the middle and your ears are on the side. That means for the processing centers, the ears must be in the middle and the eyes must be on the side. Very, very. You will for sure get questions about this. I just these pictures up. So for the hypothalamic nuclei, I have seen plenty of questions where they will show you a picture and tell you to point to it. Not so much for these, but I just threw this here because I thought it was a useful diagram. For the hypothalamic nuclei, for sure, 100% know everything on this page with a star on it, please. Mammillary bodies will usually be asked in the context of confabulations. It'll usually be asked in the context of beriberi or Wernicke-Korsakoff syndrome, B1 thymine deficiency. Definitely be aware of this, but it's probably not going to be asked in the setting of neuro. These four, I can almost guarantee you will have a question and you will have to distinguish between either the anterior or posterior or the lateral or ventromedial. Please remember that ghrelin simulates the hunger centers, leptin simulates the satiety center. So if you knock them out, you become either anorexic or you don't eat. Anterior, posterior is your temperature. I actually think we were asked about all of these. And then you'll be asked almost certainly something adjacent about this. If you're not asked about it on the test, you'll be asked about it in the final. This is one, and it's unfortunate because there's so many different diagrams of this. I should have put the one that Coelho used also on here. But just be generally familiar of roughly where these are, because I've certainly seen questions asking you to point. Granted, I think it was a question about temperature regulation, so it's really hard to mix up the anterior versus posterior. But still, be familiar with where these are actually located, unfortunately. Reflexes, not going to go super into detail. Please just know that the spindle fibers are responsible for the stretch. These are the ones that tell your body how much force you need to apply to hold something static in space. If I have a bucket and I'm filling it with water, my body can detect that the muscle fibers are starting to stretch even though I don't want them to, and it will apply more force. Golgi tendons. Oh, also, this is Golgi tendons. These are the ones that tell you if you're holding something too heavy and they make you drop it, right? It is important to know that these spindles are in parallel to the muscle fibers, whereas the Golgi tendons are in series to the muscle fibers. As far as flexible withdrawal, yeah, I don't think I've ever seen a question on this, but this for sure. For sure. Upper motor neuron, lower motor neuron injuries, you will for sure be tested on this until you sit for your, I don't know, board exams as a surgeon or whatever you want to do. You will always continue to be tested on this. It's super high. You absolutely need to know this. Lower motor neuron lesions. The lower motor neurons are only the last neurons. They're the terminal neurons. They're the neurons that terminate on the muscle itself. If you damage them, muscle gets no signal. You get hypo everything. Flaccid paralysis, hyperreflexia, hypotonia. The muscles start to deteriorate. Fasciculations and fibrillations. This is not spasming. It is more like just like quivering. I kind of like to think it's like the muscle it's just dying, right? Like it doesn't know what to do. And it just does these unregulated little fasciculations. This will be the only time this will be like a very important thing. Usually you will always be able to figure it out for the rest of the question, upper versus lower. But when fasciculations specifically comes into play is when you're talking about paralysis of the tongue and you're trying to figure out if it's the upper or motor neuron lesion of the hypoglossal nerve. And that it will describe the tongue having fasciculations. Upper motor neurons, this is anything above, right? So basically anything above the ventral horn and the spinal cord, or whatever nuclei, cranial nerve nuclei in the brainstem. Most of the descending signals are inhibitory, or they're maybe if they're not completely descending, they're from some reflex loop that's also inhibitory, right? There's some ganglion that's inhibitory. So when you have an upper motor neuron lesion, you get increased activity of the lower motor neurons, right? So you get spastic paralysis, you get hyperreflexia, hypertonia. Positive Babinski signs is huge. This is in so many questions. I just put this in here because I thought it was very useful. Know these. Class-wise spasticity, definitely see this in questions. You can always answer it with everything else in the question, though. So it's not like it's a spasticity, right? You know what happens to upper motor neuron regions. This is what I was talking about with upper versus lower motor neuron injury. So the reason this is important is because, like I said, you will have fasciculations in a lower motor neuron injury. I've seen a question before that described fasciculations in the tongue. I'm pretty sure it used the word fasciculations, and it asked if it was a contralateral or ipsilateral paralysis of whichever nerve or pathway, right? It'll be like, this is caused due to a lesion in the 9th cranial nerve, ipsilateral, on like the ipsilateral 9th cranial nerve lesion, or contralateral 9th cranial nerve pathway lesion. I understand this is not the 9th cranial nerve that does this. I'm not trying to confuse you guys, but like it will have those as answer choices. Then it will have like 10 contralateral or ipsilateral, and then it'll have 12 contralateral or ipsilateral. And because it said fasciculations, you're supposed to know that's a lower motor neuron injury. The nerve itself, cranial nerve itself, right? Cranial nerve symptoms are always on the same side. So cranial nerve lesion to 12, case the face, right? It'll be on that same side, right? Deviate to the left, it's left cranial nerve. But, and it is tricky wording, but it is technically correct. You can have a deviation to the left, and the question can ask you which, the question can ask you which, the pathway of which cranial nerve. And the answer can still be like the left cranial nerve 12, even if it's going to the right, if it's above the 12th nucleus. I know that sounds, the only reason I'm emphasizing this is I 100% got this question wrong. And I was very upset about it, but this is technically correct. Just look if they give you this question, look to see if there are fasciculations or spasms of the tongue, because it will tell you if it is an upper motor neuron lesion or a lower motor neuron lesion. And if it's an upper motor neuron lesion, it is in the cortical bulbar tract of that cranial nerve, which makes it on the contralateral side of the head. If it's a lower motor neuron lesion, it is in the cranial nerve itself, right? Which makes it on the ipsilateral side of the head. Again, the only reason I emphasize this is because I know that at least once, maybe twice, it was specifically asked on an exam I've taken within the last year, and I got it wrong. Bell's palsy, super duper 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 important. Remember that the top half of your face is only is controlled by both sides of your brain, whereas the bottom half of your face is only controlled by the contralateral side of your brain. So if you have paralysis of half of your face, that means that you have a 7th nerve palsy. If you have paralysis of your nose and mouth on one side of your face, but your eyebrows and everything is fine, that means you almost certainly have a cortical stroke. Very important to understand Bell's palsy. It could also be a internal capsule stroke, but the point is if half the face is messed up, it's the nerve. If a quarter of the face is messed up, it's the brain. I would rather have nerve damage than brain damage. So just Bell's palsy, really important. Strokes, I'm sure this is beaten to death. ICA, MCA, PCA. Do not think that because you were tested on it on the first exam that you don't need to know the circle of Willis or the blood supply in the brainstem. You will 100% need to know that for this exam. This is how they will ask you the stroke questions. This is how they will ask you the brainstem stroke questions. This is how they will ask you some lower motor neuron questions. I highly recommend, if you cannot right now, draw me the circle of Willis and that little diagram that I taught in the tracts and lesions review. Go back, rewatch the recording, and know how to do it, because you will almost certainly need to be able to do it for this exam also, and also the final, and also comp, and also step 1, and probably step 2. But yeah, you guys know it. I'm not gonna waste your time with this at this point. Watershed strokes, just a quick reminder. It's just like in the gut, wherever you have the they're not quite anastomoses, but they almost anastomose. That's where the vessels are the smallest. So it's highly susceptible wherever the AC and the MCA meet and the PC and the MCA meet to hypovolemia. So if you have hypovolemic shock, you're susceptible to watershed strokes. If you have any type of hypotension, maybe during surgery, during an injury, you can have strokes, these watershed strokes. Based off of where this is located, it typically affects the arms. Watershed strokes typically either affect, you'll have paralysis of the arms, or you will have vision impairments because it thinks the loop of mind as it passes through, you loses blood supply, the whole area becomes damaged. Farm for strokes, the really big thing here, usually if they're going to ask you a question about this, it's going to be, why can't you give this patient TPA? If there's any contraindication for TPA, you can't give. Most of the questions I've seen have been about, it'll talk about, the patient will check all of the other boxes, like recent large clot, they have neurological deficits, right? Like you need to know this for sure. You absolutely need to know this. Obviously it can cause bleeding. No, you treat with tranexamic acid. If this is the one that usually gets asked about, not immunocoproid, tranexamic is the one that I've seen a lot more as an answer choice, but this is usually what they ask questions on, is the contraindication for TPA. Know what clopidogrel does. Know that it's an ADP receptor inhibitor. ADP is the receptor on platelets that lets them activate other platelets. No dual platelet therapy, clopidogrel and aspirin, 100%. Super important. I've definitely seen questions, more than one question, where it asks about like follow-up treatment. What do you discharge the patient on specifically? And dual platelet therapy is 100% something they should be on. And then the answer will either be like non-selective permanent COX inhibition, right, for aspirin, or it will be ADP inhibition. For localizing the cerebellar lesions, there's like a little nuclei here. He went into a lot more detail about this than I've ever seen a question on it, even on the block exams. Know that the person's laid across the middle. The closer you are to the center of the cerebellum, the closer you are to the spine as far as paralysis. So if you have something in the central vermis, a lesion, you're gonna have truncal ataxia. If it's on the periphery, you're gonna have problems with movement of the limbs. Danny Walker syndrome, don't forget that. This doesn't form. Obviously, you're gonna have a lot of problems, right? That being said, I don't think Danny Walker is on our second exam. That also being said, anytime I've seen a question on Danny Walker, I'm pretty sure I've seen the CT, right? It'll show you see like the brain, and there's like the really striking, like just huge hole where the cerebellum should really technically be. And you just stop reading the questions like Danny Walker and move on. Other type of cerebellar lesions, be familiar with all these terms. There's not much more to say about that. Definitely be familiar with all these terms because they'll use them in stems, and then you'll have to, they won't like describe what's happening. Like sometimes they'll just say to the patients or whatever. Or they'll talk about patient failing the heel to shin test. I've actually seen that quite a few times. And you need to know that it's going to be a cerebellar lesion. Friedreich ataxia. I talked about this before. Know that it's a GAA repeat. Know that it's a frataxin gene. They usually die of hypertrophic cardiomyopathy. Trying to think of other things they'd like to throw in these stems that you know immediately. It's Friedreich ataxia. I think I said last time, I've seen one question where it talked about that it's actually disorder with iron metabolism. I definitely got it wrong. I was very confused. But it might be something to just think about. But yeah, Friedreich ataxia, usually for these triplet repeat disorders, a lot of times they're asking you what the trinucleotide repeat is. It'll describe the patient. You'll need to know that it's Friedreich ataxia. And then you'll need to know that it's either a GAA repeat, or you'll need to know that they're susceptible to hypertrophic cardiomyopathy. I've seen that a lot too. As far as the limbic system goes, they don't test on the specific too much. They really only test on the pathology. It's much higher yield. Kluver-Bucy syndrome. This is damage to the amygdala. You will almost certainly have in the STEM, it'll be like a dude in his like 40s or 50s that's just like become hypersexual out of nowhere. But the hyperorality is honestly a bigger giveaway in a lot of the STEMs. If I'm kind of on the fence about whether or not they want me to say that some dude has Kluver-Bucy syndrome or like frontotemporal dementia or something, and it doesn't talk about any like weird him exposing or playing with himself or sticking things in his mouth, I'm usually not going to say Kluver-Bucy syndrome. They give hyperorality a lot in this one. Um, for the mammillary bodies, like I said, Wernicke-Korsakoff, huge. Wernicke-Korsakoff, confabulations. Once you have confabulations, once the patient starts making stuff up without knowing they're making stuff up, it's Korsakoff syndrome. And then the thiamine B1 deficiency, this is beriberi. If you have cardiac involvement, it's dry or wet beriberi. This is caused by alcoholism. Yep, that's basically it. There's the Phineas gauge thing, right? Any damage to the prefrontal cortex will affect mood. You can get like a completely new personality. Motor neuron diseases. Yeah, you'll definitely be tested on at least one of these. Every time I've been tested on this, they've asked what the mutation was. SMN1, survival motor neuron gene. If you don't have survival motor neuron gene, your motor neurons die. I'm pretty sure they're specifically alpha motor neurons. I don't really think that's super important, but this is floppy baby syndrome. But this is definitely lower motor neuron degeneration. Polio is also lower motor neuron degeneration, right? So these are both flaccid paralysis. I talked about the one-hit syndrome thing, which I didn't include too much of the med micro for this because it really would have just been me copy and pasting Dr. Finkel's slides. And it's such a small part of this, and I'm sure you guys, there's so few things to know about each one that I'm sure you guys have it by now. But a lot of times when they ask about polio on the comp exams, it's about the vaccines. So make sure you know like the Salk versus Sabin vaccines. And then know that polio likes to live in the ventral horn of the lower spine. This is my hypothesis for why polio seems to affect the lower limbs more than the upper limbs, because this part of the ventral horn of the lower spine is bigger than the thoracic or upper spine, right? So it's more of the virus. And then ALS, Lou Gehrig's disease. If you see a question stem that has mixed upper and lower motor neuron symptoms, you know for sure 100% it is ALS. Niemann-Pick type C, 9 times out of 10, they're asking you to distinguish between this and Tay-Sachs. How do you distinguish between this and Tay-Sachs? Hepatosplenomegaly. If you don't see hepatosplenomegaly in the stem, it is not Niemann-Pick disease, it is Tay-Sachs disease. Sometimes they'll ask you for the genes. Niemann-Pick type C, NPC1 and NPC2. Most of the genes for this block, it would be really hard to get them wrong in a multiple choice test. As far as all the dementias go, for Alzheimer's, this is the most progressive of them all, right? It starts with short-term memory loss, and then super duper late, they'll end up with personality changes. Neurofibrillary tangles and amyloid plaques, super high yield. You need to know that term, right? So you get just degeneration, right? The genes, presenilin 1, presenilin 2. The reason you need to know these is because they're on chromosome 21. People with Down syndrome are susceptible to Alzheimer's disease. They get it at a younger age. Generally, if a person is getting these symptoms and they're 40 or 50, it's not Alzheimer's. However, if a person has Down syndrome and they're getting this at 40 or 50, it usually is Alzheimer's. Know this. Definitely got a question on this. ApoE2 is protective. ApoE4 increases your risk. Vascular dementia will be very gradual. There won't be any sudden onset of symptoms. And in the question stem, it'll talk about the patient having like a history of a lot of strokes or a history of like really bad heart disease. They don't ask a whole lot of questions on this unless you get some type of imaging to go along with it. Frontotemporal dementia, there's a couple different things that can cause this. Niemann-Pick disease is one of them, right? You end up with the pick bodies, which is they'll ask about this too. So it's the tau protein, which is also an Alzheimer's, right? But this ubiquitinated TDP, I have somewhere what this is for. But we ubiquinate things when we break them down, and even pig disease, you can't break the things down, right? So you end up with a bunch of this ubiquinated. Knife edge diarrhea, this is huge. I saw this picture up with Google, right? You have these really sharp degenerations of the gyri. Lewy body dementia, alpha synuclein. This is really high like correlation here. A lot of times they'll ask about, you'll see the Lewy bodies. They'll ask what they're made of. Alpha synuclein. Your normal pressure hydrocephalus. Oh, I flipped the order of these slides, just realized. You will see increased size of the ventricles without compression of the gyri and the sulci. So you'll still see the sulci, and the gyri won't look like they're all like mushed together. But your ventricles will be dilated. Incontinence, ataxia, cognitive changes, right? This is super high yield. I saw a ton of questions on NPH. Creutzfeldt-Jakob disease is a prion disease. This is the terrifying one, right? We can't do anything to stop it. A lot of times they'll just give you this picture. And by this picture, I mean actually this picture, like quite literally this picture. This is in the step book. This picture is also, I think, in one of the PowerPoints. And this picture is also on one of the forms. So know what this picture looks like. And I mean, literally this exact photo was on all three of those things. So yeah, but know what prion disease looks like under a microscope. Also know this, you can detect it with 14-3-3 protein in the CSF. Spongiform degeneration of the cortex is a huge buzzword, but this will be somebody in like their 40s or 50s with rapid progression of dementia-like symptoms with behavioral changes and even seizures. Usually they don't talk about the seizures, but rapid behavioral changes and cognitive decline is kind of like the good way for prion disease. And then HIV, if you have really bad, really late stage HIV, your CD4 count's in the gutter and you're about 60 years old, you can get HIV dementia. And the question will either tell you they have multinucleated giant cells in the brain and want you to know that it's HIV dementia, or it'll say like, what could this patient also be at risk for? The answer will be literally anything that an immune compromised person is at risk for. It may ask you about the characteristics of the causal organism, HIV, or it'll make it really clear that the patient is immune compromised. It's not so much of an issue for you guys on this one because you don't have like the encephalitis and the meningitis on this exam also, but on the final, these question stems can sound an awful lot like HSV encephalitis. It'll just be in a little bit of an older person, or it'll sound like, I don't know, toxoplasmosis, because they'll give you a bunch of hints, right? You'll see that the person is immune compromised, and then you're like, oh, they're immune compromised, toxoplasmosis. But no, it's if their CD4 count is like in the gutter, like I think it's less than 100 is the cutoff. Then they can have this, and sometimes they'll want you to say that you could see multinucleated giant cells on a microscope. I just put a little thing here so it's easy for you guys to keep track of. SOD1 is the ALS gene. It's kind of weird. Superoxide dismutase. I mean, you guys all know what superoxide dismutase does, but it doesn't. What does that have to do with ALS, right? Hard DNA binding protein 43. Just remember TDP 43 is the search for the frontal lobe dementia, and then you know the rest of it. Onto the basal ganglia. This is all of your movement disorders. This is all your Parkinson adjacent disorders. Really big, really big. They want you to know and be able to point out on a diagram where these diseases affect from both views. Huntington's disease affects the striatum, which is technically the caudamen and the caudate and the putamen. However, usually they're looking for the caudate nucleus. Wilson's disease affects the lentiform nucleus. And I suspect the reason why they usually ask about the caudate specifically is because both Wilson's disease and Huntington's disease affect the putamen, right? Putamen, however you want to pronounce that. I don't know how it's pronounced. English is my first language. I'm still not very good at it. But usually, like I said, usually with Huntington's, they ask about the caudate nucleus. And then Wilson's disease, they're not usually asking about where Wilson's disease affects. However, it is easier because with Wilson's disease, the arrow will just be pointing like generally here. And it's a lot easier to distinguish between this than having to like pick between these two. For Huntington's, right? Subthalamic nucleus, that is pathognomonic with hemibolismus. If you see subthalamic nucleus damage, assume the patient has hemibolismus. If you see the patient has hemibolismus, assume that they have subthalamic nucleus damage. And then Parkinson's, again, substantia nigra, super high yield, decrease in dopamine. They'll physically will look less dark because dopaminergic neurons are very dark. And I think I have a question on that somewhere. Maybe not thinking about the basal ganglia, the D1 and D2 pathways. The D1 is the direct pathway. This facilitates movement. The D1 is the indirect pathway. The indirect pathway inhibits movement. And the way they do this is a little bit backwards because the global pallidus interna, remember how I said earlier, how when you have upper motor neuron lesions, you have spasticity and rigidity and hyperreflexia because the lower motor neurons go kind of crazy because most of the signals they're getting are inhibitory. The global pallidus interna is the one sending most of those inhibitory signals. So if this inhibits movement, then in order to stimulate movement, you need to inhibit this, right? So D1 inhibits this. D2 stimulates this. D2 inhibits movement. D1 increases movement. That is really what you need to know. And then, I mean, know that it's glutamate and GABA for this process. You might get a question on that. You can figure everything else out based off just knowing those things. Parkinson's disease. If you see shuffling gait, if you see mask-like face, it's Parkinson's disease. I don't care what the rest of the stem says. If you see these words together, it is Parkinson's disease. They'll also describe the pill rolling tremor, which is also specifically Parkinson's disease. This is where I was talking about how you can see normally dopaminergic neurons in the substantia nigra are dark. That's probably why it's called the substantia nigra, because the dark part, right? You lose the like it gets lighter, right? When you lose those neurons. You get Lewy bodies in Parkinson's. That is not the same. They are the same Lewy bodies that you get in Lewy body dementia. However, this does not mean that you have Lewy body dementia. This is just alpha-synuclein deposits. Alpha-synuclein is super high yield. You need to know that word for sure, 150%. Also know that it is in the substantia nigra pars compacta is where this happens. You may have to point to this on a picture. Very likely you'll have to point to this on a diagram. Huntington's disease, that's another one of our repeat disease, CAG, which is they make like a mnemonic for, right? Caudate loses acetylcholine and GABA. So in Huntington's disease, you have increased dopamine in the caudate nucleus. You have decreased GABA and acetylcholine. Good effects. Huge thing with this, anticipation. They'll describe like someone who is like in their 20s and is having symptoms, and their uncle had it in his like 40s. It says it's a toxic gain of function mutation, right? This autosomal dominant. I think most of the expansions are autosomal dominant, but it's a gain of function. It says pro-apoptotic. I'm pretty sure it's an unfolded protein response, but if they want to call it pro gain of function, that's fine. They can call it whatever they want. Just know that. And it actually kills the neurons through glutamate toxicity. So if you stimulate neurons too much, they end up dying, right? They get destroyed. Yeah. Aggression's a pretty big one here too, but yeah, just know this specifically. The caudate, this is so high yield. The caudate and the anticipation, and then knowing that dopamine's up and GABA and acetylcholine are down is super duper high yield. Huntington's, it's like chromosome 4. I think somebody said that Hunt has 4 letters in it. It's one of the dumber ones, but so is mine, right? Speaking of dumber ones, Wilson's disease, it's like chromosome 13, right? We talked about this. Wilson's sporting goods, founded in 1913. Why? I don't know, because the world's stupid. This onset's super early. A lot of times when you hear them talking about Wilson's disease, they'll describe the kind of like Fisher rings, calf rings. This is due to an accumulation of copper. Basically, you have a mutation in the ATP7B gene, which helps you get rid of copper. Because of that, you'll have decreased ceruloplasmin, which is what binds copper in our blood. So it makes sense. The reason it's decreased is because it's bound, right? and you'll have increased serum copper, increased copper in the urine. It's just such a dead giveaway for Wilson's disease, right? Which is why they usually ask stuff that's not like, hey, what is this? So they usually ask about this gene specifically, or they'll ask about penicillamine as the treatment. It's a chelating agent. Finds the copper so you can urinate it out. How do you diagnose this? Either seroplasmin levels or slit lamp examination. This is a weird thing when you hear someone talking about ataxia, right? It may be weird when they ask you what confirmatory test should you do first to say, give them an eye exam. But I promise it has been the answer on the question for me. Hemibilismus, I said it before. Subthalamic nucleus, hemibilismus. Hemibilismus, subthalamic nucleus. And I just added genes, right? I just added ATPC, and the CAG repeats here probably because Wilson's, just so you have it all in one place. The drugs for this. So there's maybe four things that I like to ask about a lot with the drugs for this. Levodopa, carbidopa, you 1060% need to know this. I'll go into more detail on that on the next slide. As far as the other ones, know that you need to know the classes of these. So you need to know that the G-lines, are the MAO-B inhibitors, not to be confused with when you say monoamine oxidase inhibitor. Normally, you're talking about the psych drugs. Those are monoamine oxidase A inhibitors. Monoamine oxidase B inhibitors are for Parkinson's because monoamine oxidase B specifically breaks down dopamine. So know that the glycines are the MAO-B inhibitors and know that the capones are the COMT inhibitors. Just know dextromethorphan and trihexylphenidine are the central anticholinergics that we use to treat these symptoms of Parkinson's disease. And then you have like your dopamine agonists, right? Levodopa, carbidopa. This is a super important one. Levodopa, dopamine cannot cross the blood-brain barrier. Levodopa can. Our body converts levodopa to dopamine. So in order to increase dopamine in our brain, we have to give ourselves levodopa, which then crosses the blood-brain barrier and then gets converted to dopamine by dopamine decarboxylase. The problem is we have dopamine decarboxylase ever in our body or dopa decarboxylase ever in our body. So we get peripheral conversion, which leads to a lot of side effects, right? So how do we fix that? We give a drug that specifically inhibits dopa decarboxylase that also cannot cross the blood-brain barrier. So when you give these drugs in combination, you end up with a decrease in peripheral dopamine conversion, and you end up with an increase in dopamine in your brain. So when they ask me a question, levodopa treats the symptoms. Carbidopa reduces the side effects. Very important you understand that. The aphasias, almost always when you're asked about this, it's going to be Broca's versus Wernicke's aphasia. And a lot of times they'll explain and then they'll ask you where the damage is. And you might have to like literally point to it on a brain. I think we had a question where it was like A through J. There were so many spots pointed to on the brain. But overwhelmingly, the majority of questions are going to be Broca's versus Wernicke's, right? Broca's is broken speech. They can't get the words out, right? Wernicke's, it's your word salad. They're speaking fluent sentences. What they're saying, they believe makes sense. The words that they're saying are not the words that are leaving their mind. So they're just saying absolute gibberish to you, but they are words. They just don't go together, right? Conduction aphasia. This is when you have damage to the arcuate fasciculus. So in a really convoluted way, basically what happens is they can like kind of talk, but what they can't do is they can't repeat a sentence back to you. And the reason for that is because the auditory processing center is also like in here somewhere. So they hear what you say and then they try to say the same words, but they can't. So either they say something adjacent, like if you tell them to specifically repeat after you, like to give you the same sentence back, they just can't do it. And a lot of times either they'll say another sentence that's like kind of loosely related, but is certainly not what you said even remotely, or they'll just repeat the question back to you. Like if you ask them a question, they'll repeat the question back. Like they can't repeat. They cannot repeat like what you say. Like the words, the specific words that you give them, they absolutely cannot put those back out of their mouth. Transcortical and global. For transcortical, they can repeat. They can repeat, and they do repeat. You're not going to get asked questions on these. If you see a question where the person keeps using stall words over and over again, like yep, okay, and by over and over again, I mean like literally like yep, then it's global aphasia. But I've seen so little questions on this in hundreds, maybe even more than 1,000 neuro questions. I have so few questions on this. Know these two, and be aware that this one exists. And be specifically able to point to Broca's area and Wernicke's area. Parietal lobe disorders. This is like your weird spatial neglect, hemi-neglect, and like your acalculus and alexias. So basically the angular gyrus sits right here. If you damage the angular gyrus on the left side, usually the left side, which is the same as Wernicke's and Broca's, right? It's usually damage on the left side. It's usually the left MCA. You can lose the ability to read, write, or do math. But the important thing here is you have to have had the ability to begin with. It is very specifically the loss of an ability that you previously had. Yeah. If you damage your parietal lobe on the non-dominant side, you get spatial neglect. So how you get hemi-neglect is non-dominant, usually right side parietal lobe damage. And then, again, like we were just talking, dominant parietal lobe, that's your left and right confusion, your Gerstmann syndromes, and your aphasias. Headaches. See more questions on these than I thought you would. Cluster headaches is a really big one. That'll be usually like a young male, young adult male. Terrible headache centered around specifically one eye. The eye can be red. They can be crying, like tearing on that side. That side of their face can be sweating. They almost have like Horner-like syndromes. Cluster headaches. How do you treat it? 100% oxygen. That's usually what they want. Technically, you use triptans, verapamil for prophylaxis, but it's usually they're asking about oxygen, or they're just asking if this is a cluster headache. Also, these are the ones that sometimes they'll just ask you what it is, and it's like, okay, cool. Tension headache. These are the band-like headaches. These are the most common types of headaches. Happen to females. They don't ask very many questions about tension headaches. Migraines. I feel like in today's day and age, everybody knows what a migraine is, but the things that they like to specifically talk about are the aura and the photophobia. This is also unilateral, and they pretty much have to be like repetitive and episodic. You can treat this abortively with triptans and NSAIDs and Tylenol, but generally, you put them on. They want you to know that you put them on like some type of prophylaxis. You can use anti-CGRP antibodies. I've seen this spelled out to like antibodies against calcitonin related. This is calcitonin gene related peptide. I've seen it spelled out in like long form in a really weird way as a test answer before. You can also treat with valproate for prophylaxis. And then your honorable mention is, because I didn't know where else to stick it, with pseudotumor cerebri, which is idiopathic intracranial hypertension. This is going to be an obese female, 30 to 40. Headaches. She'll have blind spots, either scotomas in her center-ish field of view, or she will have loss of her peripheral view, kind of like tunnel vision encroaching in, and she'll have papilledema. And the reason why and she'll have 6 nerve palsy. And the reason this is happening is they don't really know, but it is causes some type of increased intracranial hypertension. Yeah, it's really obvious. It's really obvious when this is what they're asking for, and they're usually asking for pseudotumor cerebri or intracranial idiopathic hypertension is the answer. If they give you a specifically obese female with like headaches and vision problems and it's bilateral, it's this. If it's unilateral, you can think about migraines. If it's bilateral, it's this. All right, onto the psych portion of this. You do not need to know which ones are cluster A, which ones are cluster B, and which ones are cluster C. I think it's pretty easy to remember because A is the weird ones, B is the dramatic ones, and C is the anxious ones. But it's not super important that you remember. What it is important is that you can pick out these in the question stem. Just real quick, schizotypal. The patient's really weird, and that's it. Just like real weird, super duper weird. They can have absolutely crazy beliefs about things, borderline delusions, but it's not affecting their daily life. Therefore, it is a personality disorder, and she doesn't have like schizophrenia or anything. Real eccentric people, right? This is one they ask about a lot. Paranoid. Usually, they don't ask about this one because unless there's this question some specifies personality disorder, because it would be really hard to distinguish this between some of the schizoid disorders, right? Speaking of schizoid personality disorder, right? This is just a person who like doesn't want friends. They just keep to themselves at home. They don't want friends. They have no problem with not having friends. Borderline personality disorder. This person's hot and cold. They're all over the place. This is like usually it'll be like someone who breaks up with their partner and gets back together with their partner and causes problems at work, and then breaks up with their partner and then threatens to kill themselves and then makes multiple suicide attempts. This is the one that they're really likely to display splitting. Yeah, very impulsive. They almost always, in order to put that, if you're going to put this as an answer choice, you better find some form of self-harm somewhere in the stem. And now that might not necessarily be specifically like suicide attempts or cutting or something like that, but they have to be doing something that's self-destructive. Histrionic, needs attention. Antisocial. This is the evolution of, what is it, defiant disorder in kids, where you are specifically doing things that are causing damage to property or people or society just because, right? Do not confuse these two. When you say someone is antisocial, you think of schizoid disorder. But when you describe schizoid disorder, a average person would think, oh, that's an antisocial person. No, antisocial is specifically you're doing bad things because you can and you feel you don't see why not. Narcissist needs to be the center of attention. I think everybody knows a person like that. Dependent. They don't really ask questions on this. If they do, it'll be really obvious that someone basically like completely relies on their partner or their mom to basically make all their life decisions for them and is paralyzed when they're not around them with anxiety. Avoidant. This is people who don't have friends because they're afraid that their friends are not going to like them. So this is schizoid is a person who doesn't have friends and they're happy about it. Avoidant is a person who doesn't have friends and they're sad about it. Or anxious about it. And then OCPD, obsessive compulsive personality disorder. If you've ever heard somebody say, "Oh, I have OCD about that," this is it. It's not actual OCD. It's an OCPD, right? Things have to be a very specific way. If you don't get these and you're getting questions wrong in these, what I highly recommend you do is pull these descriptions up, maybe even the long form ones from the step book, and attach either celebrities, pop culture figures, characters from your favorite book series. I think I've seen like I saw someone had like a Harry Potter version of one of these, right? Or do what I did and write your friends' names down, because that helps it stick real well. Eating disorders, 100% gonna have a question on this. They want very specific things, so they definitely test you on the farm of this. No, this for sure. No olanzapine for sure. Know that you treat bulimia with fluoxetine, know that you treat anorexia with olanzapine. Please know this. Also know that if someone has any of these eating disorders, you do not give them Wellbutrin, bupropion. Do not give them Wellbutrin. Any eating disorders at all. You also don't give them any amphetamines or any stimulants. For anorexia, on the exam, they have to have a low BMI. Technically, this is not true. And very obese people can develop anorexia and rapidly lose weight and starve themselves, and they will still have high BMIs. That is a subcategory of anorexia. But for the purposes of the exam, if their BMI is not below 18.5 kilograms per square meters, they do not have anorexia. The other really big thing here is they're like afraid of gaining weight, and they have like avoidant behaviors to avoid gaining weight, and they have body dysmorphia. To have anorexia, you also sort of have to have body dysmorphia. For bulimia, everybody associates bulimia with vomiting. However, you have to also binge to have bulimia. Bulimia requires two parts. It requires binge eating and then some type of compensatory mechanism, which doesn't have to be vomiting. It can be you eat a bunch and then you starve yourself for 3 days. It can be you eat a bunch and then you look at the mirror and call yourself a fat, lazy POS afterwards. You have to have some type of reaction to eating a whole bunch to try to either stop yourself from doing it again or to alleviate it. You eat a whole bunch and then you go work out a whole bunch. You have to have binge eating and some type of compensatory response in order for it to be bulimia. If you see that they are binge eating and there's compensation, it is just assume it's bulimia. Treat it with an SSRI, specifically fluoxetine. And then binge eating disorder, you have no compensatory response. And it's important to know, once again, binge eating, somebody's depressed, they're binge eating, you do not give them Wellbutrin. Even though it would solve both problems, you still don't give them Wellbutrin. You do not give anybody with an eating disorder Wellbutrin. As far as the mood disorders goes, so these are very timing based. I'm not gonna like sit here and like dig through the details. So you need to be able to distinguish in the stems what is hypomania versus what is mania. Hypomania is I'm feeling really productive. I'm going to do a bunch of things. I'm going to take on a bunch of projects. I'm going to do a bunch of stuff at work. I'm going to go. Hypermania, or what like they considered mania, is I'm talking to God. I am God. I'm the son of God. There is a wildly high correlation between religious like grandeur and mania. If you have mania, it's bipolar 1. If you have hypomania, it's bipolar 2. Dr. Chabodorov once said in one of his like off the cuff conversations after lecture, you will know if the person has bipolar 1 because the police brought them to you in the hospital. That generally reigns true. Also, they talk about unipolar versus bipolar diseases, right? Depression is a unipolar disease. Unipolar, it only goes down. Bipolar 1, you don't have to have depression. I know that's like, what? That doesn't make any sense. You can diagnose someone with bipolar 1 with just the excessive mania episodes. You don't technically have to have the depressive episodes, but in question stems, usually they'll give you both. Bipolar 2, remember, it's hypomania. They are very productive, but they're not quote unquote nuts, right? And then schizoaffective disorder. So this is, you have psychosis and depression at the same time, but you also have psychosis when you are not depressed. That is really important. So schizoaffective disorder seems a lot like bipolar disorder, except you're displaying psychotic features when you're at your baseline and not just when you're depressed. The big way to distinguish between the schizo disorders and the bipolar disorders, in my opinion, and this is also based off of a conversation that I had with Dr. Todorov, is in bipolar disorder, your actions match your mood. When you are really depressed, you stay at home and do nothing. When you are really manic, you go out and go, 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 go. With the schizo disorders, your actions do not match your mood. So you could be manic and going and going and going, or I haven't slept for 4 days, but you're super depressed. Or you could be super depressed, but now you're taking on a bunch of projects for no good reason, or you're super depressed and you're hallucinating and thinking that you're talking to God. For this, that's the best advice I can give you for reading these on stems, because I had a really, really, really hard time until basically a week before we took this test getting bipolar and schizoaffective and schizo disorders in general separate in question stems, because it seems like there's a lot of overlap. But the biggest he went like after he told me that, I like really started to get them straight. Again, bipolar disorders, your actions match your mood. Schizo disorders, that is your mood and your actions are incongruent sometimes. And then again, for schizoaffective specifically, you have depressive episodes with psychotic episodes together, but you also have psychosis when you're at your baseline. Yeah. Know these timelines super important for these, right? Like all this stuff, timeline super duper important. If you haven't been crazy for 6 months, it's schizophreniform disorder. It's not schizophrenia. So this is like schizophrenia light. And it also doesn't have to affect your daily life. Schizophrenia, you can't function as a person. Schizophreniform, you can. And then, like I said, schizoaffective, is sort of depression on top of it. Delusional disorder. Sometimes they'll give you delusional disorder, and like expect you to think that the person's being like, even if it's like it could be a paranoid delusion, but if there's only one single delusion, right? Like one dude is super convinced that the CIA is following him and watching him and has his house wiretapped. That's delusional disorder. If it is one specific delusion or all of his delusions relate to the same like one topic or cause, it's delusional disorder. As far as the drugs of abuse, I know I gave you guys different resources last time I went over this, but Dr. Trbodarov is very reasonable about testing to the things that he gives you. If he gave it to you, it's important. These are the ones that I feel are super important. Pupil dilation and pupil constriction, and then nystagmus. I feel like these give away the question stems the most. I've said it before and I'll say it again. The only difference in a question stem between cocaine and PCP is a nystagmus. Know that stimulants and hallucinogens dilate the pupils and opioids constrict the pupils. If a drug causes a problem or causes a symptom, withdrawal from that drug is going to do the opposite. That is not a difficult concept. That is why these questions should be 3 points. Know the mechanisms of actions of all of these. You should know all of them, but know the mechanisms of actions. If you don't know, if there's anything on this chart you don't know it by Thursday. And then yeah, this is just more. This is I threw this on here in case you guys didn't want to have to go dig through all the other PowerPoints. This was like the more useful of the ones he gave you. I feel like these are tested on more than the other ones. Yeah. And then again, this is the same thing, right? All of these features, right? If these are the features of somebody who is under the influence of or overdosing on these substances, the withdrawals will literally be the exact opposite. The only drug usually that they ask you like really specifically and get really into the nitty gritty where it's not just like super obvious is opioids. It's gonna sound like the worst flu anybody's ever had in the history of flus. That's like the withdrawal symptoms like heroin and opioid addictions. And then alcohol. You gotta look out for like delirium tremens, right? They ask about this more than you think they would. I guarantee you'll have a question on this. A lot of times it'll be one of these two. If If the person knows there's a problem, that's contemplation. If the person has started the process of making a change, it is preparation. Somebody who says, yeah, I know that I'm overweight, I should probably go to the gym, contemplation. Somebody who signed up for a gym membership, even if they haven't gone yet, but they've signed up for a gym membership, preparation. Somebody who has been going to the gym for 2 weeks, action. Usually they ask you about these two. These are usually the ones they want you to distinguish too. I've seen this on so many things. I had at least 2 questions on it on STEP. I might have had a third one. I just don't remember if it was on that or on the forms that I took the day before I took STEP. So please know this, please. We'll do a kind of crash course for farm. Dr. Paul is once again the absolute best. These diagrams are so useful. He does such a great job of pointing out all the important things. For the antipsychotics, the really important thing is knowing the difference between first generation and second generations. Know that first generations have D2 antagonism as their main mechanism of action, whereas second generations are serotonin. Lots of questions on this. Know that first generations treat mostly the positive symptoms. So like hallucinations, right? You're a positive symptom, you're adding something on. Whereas second generations are effective for both positive and negative symptoms. So like this depression, for example. Haloperidol is the really big first generation they use as an example a lot. I think on the other page it goes more into detail on maybe this one. But know the extrapyramidal side effects, right? And then clozapine, agranulocytosis. Clozapine, agranulocytosis. Clozapine, agranulocytosis. I'd be surprised if you didn't have this as just a question. Clozapine, agranulocytosis. They may not tell you it's clozapine. They may give you a question stem where it talks about a patient was on haloperidol. And then you switched them to a second generation antipsychotic. Like what tests do you need to do? Like what tests you need to like follow the patient, and they'll ask you to do like a CBC, like a weekly CBC. Like they can ask it in like a really obscure way, but like if they're talking about side effects of second generation antipsychotics, really, really, really think about this as what you're looking for. So then when you block the dopamine, you get a whole bunch of different side effects, right? Hyperprolactinemia, be aware of this. You guys should remember this from endo. Normally dopamine inhibits prolactin, right? But when you decrease dopamine, you're going to increase prolactin. You get infertility, you get amenorrhea, you get galactorrhea. Dopamine and prolactin are inversely related to each other. Neuroleptic malignant syndrome. This is basically malignant hyperthermia. It has roughly the same ish side effects. You treat it the same way, right? You give dantrolene, you stop medications. This is basically malignant hypothermia. It's caused by antipsychotics instead of sedatives or anesthesia. And then your extrapyramidal side effects. Super know these. Please know these. Psychosis is caused by having too much dopamine. To treat psychosis, we decrease dopamine. Parkinson's is caused by not enough dopamine. When we decrease dopamine, we can cause Parkinsonianism. Conversely, when we treat Parkinsonianism by adding dopamine, we can cause psychosis. There's a delicate balance here. If you have extrapyramidal side effects, that doesn't mean you stop dopamine blockers. Instead, you can give anticholinergics to offset the effects, right? Benzotripine, trihexylphenidil, know this, know both these for sure, 100% know these, absolutely know these. It may describe a patient that you gave an antipsychotic and now they're having extrapyramidal side effects. Maybe it'll even tell you that you gave them haloperidol, and it'll ask what to do. And the answer is not stop haloperidol. The answer is try these. Yeah. Bipolar disorder. You will never put lithium. You will almost never put lithium as an answer on what drug to start a patient on. Like 95%, I would say. If you get 20 questions, if 20 questions, the answer is lithium, one of them might be start the patient on lithium, and there must be a really wild reason why none of the other ones work. However, you'll get a ton of questions on the adverse side effects of lithium. So, lithium is used to treat bipolar disorder. It does this by increasing intracellular IP3. That's honestly not that important. This is one of the few drugs that they don't really ask you about the mechanism of action too much. I would know it, but it's not. What is super high yield is lithium causes the Epstein anomaly, which is the sometimes we'll refer to it as the atrialization of the right ventricle in a newborn, right? And it also causes nephrogenic diabetes insipidus. Why is this important? Why is it so important that you know it? Because USMLE and NBME will give you a question that very vaguely describes a 30-something or late 20s female that has diabetes insipidus. And it will not tell you that she's on any type of psych drugs, and it won't even do a good job of telling you that she has any type of psych history. However, they will want you to assume that she's on lithium and she's in nephrogenic DIA caused by lithium. Why is this a problem? Because normally you treat nephrogenic diabetes insipidus with thiazides. However, thiazides decrease renal excretion of lithium. So if you give somebody who has nephrogenic DI that's lithium induced thiazides, you will make it a lot worse and possibly kill them. You instead treat with amelioride. This is very important. Please know this. Please never forget this. Please think about this when you're studying for comp, when you're sitting for comp. Please think about this. If you ever see a 20s or 30s-year-old female with what seems like DI, ask yourself, is she on lithium? Very high yield. That being said, valproate is what they usually put people on, right? So valproate, you have hepatotoxicity and you have neural tube defects. They may describe a patient who gives birth to a kid, and the kid will have either an Epstein anomaly, or the kid will have an anencephaly, or some other spina bifida, or some other neural tube defect, and then they will ask you which of these she was on while pregnant. But for valproate, definitely know the hepatotoxicity as well. This is a pretty high yield. Also, valproate, classically used, anti-seizure drug, probably the most common one. And they will use the term valproate and valproic acid interchangeably, so you have to know both of them. Know that this exists. Know that these exist. You're not going to get a whole lot of questions on them. Bunch of questions here. Okay, anti-epileptic drugs. So, almost all of these are sodium channel blockers. So I highly recommend that for any of the drugs, and by any of the drugs, I mean ethosuximide, that is not a sodium channel blocker, know it. Ethosuximide blocks T-type calcium channels. Can't say that enough times. Ethosuximide, T-type calcium channels. Ethosuximide, T-type calcium channels. It is used to treat absent seizures. Plenty of questions. We'll talk about a young kid. They'll basically describe an absent seizure, and they'll ask you what you give them. Ethosuximide. That should be a very, very, very easy or free question. Sometimes they'll ask you what the mechanism of action of the drug that you give is. Blocks T-type calcium channels. Very important. Ethosuximide blocks T-type calcium channels. Also really important. Valproic acid is a CYP inhibitor. Carbamazepine and phenytoin are CYP inducers. Very important. Absolutely 100%. You should know this. It is very likely that they will give you a question where they talk about a patient who is on warfarin, and then they will give you either an increased or a decreased INR. And then they will ask you which of these drugs you put the patient on. These are inducers. They increase drug clearance and processing. These are inhibitors. They decrease drug processing. The other really, really big thing here, SJS. Lamotrigine and carbamazepine cause Stevens-Johnson syndrome. 100% know that. Trillion% know that. You should certainly know that. Phenytoin, usually you're not going to put it as an answer to treat something. However, they will ask about all these weird side effects. I've seen gum hypertrophy plenty of times in question stems. Maybe once as an answer choice, but a lot of times they'll tell you the patient has gum trophy or this facial coarsening. It's really weird. They'll talk about like sharpen like ridge lines, or they'll describe some way that their like orbital area is changing, paired with this or like hirsutism or something, and they'll want you to know that they're on phenytoin. Also, carbamazepine, just like clozapine, causes agranulocytosis. So sorry, you have two C drugs that cause agranulocytosis. Although maybe that makes it easier. If you just associate C drugs with agranulocytosis, there's a good chance you'll get it right on the test. And the other thing, carbamazepine is used to treat trigeminal neuralgia. Just a weird fact that I've definitely seen come up a bunch of tests. Once again, valproic acid, we just talked about hepatotoxicity, neurotube defects. Yeah. Also, static epilepticus. If somebody's having a seizure for, I think it's more than 5 minutes. Don't quote me on that. Look up what that is. You should know that. I should know that. You need to know that. What static epilepticus is. I think the cutoff is 5 minutes. But basically, if someone has a seizure that won't stop, you give them benzos to fix it. All right, I'm asleep. I'm not gonna lie. This is not high yield past Thursday. So I guess whenever your final is, past whenever your final is. I don't know. There definitely wasn't a question on any of this during STEP, and I don't think there was a question on it on any of the forms I looked at. But it's not hard, so you should know it. Basically, they break up sleep into non-REM sleep and REM sleep. We think of, let me rephrase that. The general population thinks of REM sleep as like the deep part of sleep. That is not true. The deep part of sleep is actually stage 3 sleep. Here, and in his slides, he has stage 3 and stage 4 as separate stages. I've seen plenty. All right, cool. So I was right. Thanks, Alex. So it was 5 minutes. Okay, static epilepticus, 5 minutes. Go with your gut on exams. I thought it was 5 minutes. I second guessed myself. Anyways, a lot of sources basically combine these two and say stage 4 is made up. But delta waves is like your big giveaway. Delta waves, you need to associate delta waves with stage 3. The other thing, you need to associate spindles and K complexes with stage 2. Aside from that, you don't need to know too much about the EEGs here. The other big thing, though, that you do need to know is you spend half of your night in the second stage of sleep, which is where you have your spindles and your K complexes. This is the light sleep. This is where we believe we do all of our memory processing and memory consolidation. Stage 3, this is your deep sleep. This is when you get like your actual like rest. This is also when like your body is, I'm 90% sure, producing the most amount of like growth hormones for like muscle regeneration and stuff. However, this is also when all of the like pathology happens. So bruxism, which is like grinding your teeth, happens in your deep sleep. Night terrors happen in your deep sleep. Sleepwalking happens in your deep sleep, and bedwetting happens in your deep sleep. All of these things, what do they have in common? You don't know or remember that you're doing them. You are not forming memories here. In stage 3, you are not forming memories. Your brain activity is about as low as it'll ever be until you're dead. Or until after you take STEP, because man, I was wiped for a couple days. But yeah, it's very important. This is definitely important. No delta waves, no spindles and K complexes, no these happen in stage 3. REM sleep. So during sleep, we drop in and out of REM sleep. The first REM cycle is the shortest one, and they get progressively longer. About a quarter of our sleep is REM. The important thing to know about REM sleep is that as we get older, we get worse at dropping into REM sleep. We stay in it for less time. We fall in and out a bit more. So as you get older, your sleep cycle changes by you have longer latency. So it takes you longer to drop into REM. You have less REM, and you wake up earlier. Right? That's how it changes with aging. Narcolepsy. This is a decreased REM latency, so you'll drop into REM quickly, and sometimes without warning, inappropriately. This is caused by a deficiency in orexin or hypocretin. They're both the same thing. They're just two names for the same thing. And you can treat with modafinil, which is a non-amphetamine CNS stimulant. I would 100% know this for your test on Thursday and your final. How does it work? They don't really know. It decreases GABA and increases dopamine. That's like their working theory, which is like, okay, cool. That makes sense, I guess. But they don't actually know how it works. But just know that modafinil treats narcolepsy. Narcolepsy is a deficiency in orexin hypocretin. Specifically known, narcolepsy is decreased REM latency. I'd be surprised if that wasn't just specifically a question. Nightmares. Nightmares happen in REM sleep. Why? What is the difference between a nightmare and a night terror? We remember nightmares. Dreams and nightmares happen in REM sleep. We remember them. Night terrors, bruxism, sleepwalking, bedwetting happen in stage 3 deep sleep. We don't remember them. Very important to know that distinction. And then REM behavior disorder. So basically, when we're asleep, the pons sends descending glycinergic inhibition to our body, so that our brain doesn't tell our body to move when we're sleeping. So as you get older, especially in males, you can lose those glycinergic neurons in the pons. And then what ends up happening is some of the signals that our brain is sending to move in our sleep as we're like running around in our dreams or, I don't know, fighting or whatever, you'll start to act them out. So you'll see like a question stem with a dude who's like, I don't know, like 65 or 70, and he's just recently like started like just boxing his wife like in bed in his sleep, like kneeing her, like flailing around, doing whatever. Like he's not like screaming, and these aren't like PTSD night terrors where he's like waking up in fight or flight mode. Like he's just moving, he's flailing about in his sleep. REM behavior disorder. Decrease in glycinergic neurons, decrease in glycinergic inhibition, stems in the pons. For you're really, I thought for sure we would get questions on EEGs. I think we had like 2. Know this. In absence seizures, you have spike and wave. That's it. Just know that. Know that in absence seizures, you have spike and wave on the EEG. Epilepsy is also something that I thought would be more tested on. If you generally understand what epilepsy is, you can usually figure out all the questions they ask you. But like the things that are like super important, and like the way that like I think it should just be broken down is like grand mal seizures, these are tonic-clonic seizures, tonic-clonic seizures. This is your stereotypical seizure. Petit mal, absent seizures. These are the spike and wave on the EEG. These generally happen in kids. If you see this, you treat with ethosuximide. Juvenile myoclonic seizures. If it describes somebody between the ages of like 13 and 25, I think is the range I've seen in question stems, who has a seizure right when they wake up in the morning, it's juvenile myoclonic seizures. Temporal lobe epilepsy, the dead giveaway in these question stems is usually the patient smells something weird. They'll have gustatory, olfactory, or auditory hallucinations, or even visual hallucinations. And like they'll smell like burning rubber or something right before the seizure onsets. And then febrile seizures, it'll be like a kid who has like a viral infection. They have a seizure. When the virus goes away, the seizures go away. There's no permanent damage. It's not likely to happen again. Or it's not like they're not like more susceptible to seizures or epilepsy in the future. Big thing about this is we don't treat febrile seizures. You just treat the fever. And then static epilepticus, if it won't stop for 5 minutes, it's an emergency. You give them IV benzos or barbs. And that is all that I have for you guys today. Does anybody have any questions? Does anybody want me to go back over anything? Because it was an exam review, I know I kind of hit everything a little bit lighter than I normally do, but I wanted to get through everything and make sure that you guys had enough time to go do your own studying. I don't have practice questions, to be clear. This is if you guys have questions.
I had a question. Earlier when you were talking about fasciculation.
Ooh. One second. All right, try again. I don't know why my headphones just like. All right, I can hear you now.
Earlier when you were talking about fasciculations, did you say it was able to be described as spastic? Is that what you said? Or not
No.
spastic?
The term spasticity is specific to upper motor neuron injuries. However, if you gave a normal person the definition of spastic and the definition of fasciculations, they would look at them and say, what's the difference? Fasciculations are much more nuanced. They're much more subtle. So like maybe if you saw like, I don't know if you can see like, can you see the muscles moving in my arm?
Yeah.
So that would be more like a fasciculation where like the whole muscle is not contracting, but the individual fibers are firing, like one fiber at a time, not the whole muscle together. Spastic, the whole thing would be contracting and going and contracting and going. So specifically when you get to the tongue, it's a little weird because the difference between a spastic tongue and a fasciculating tongue isn't a whole lot, right? So just for that one very specific case, you got to really read through the stem and try to see if they're trying to explain fasciculations, where again, it's just like the muscle itself isn't really contracting, but the individual fibers are firing in no type of synchronous way whatsoever. That's fasciculations. It is what any reasonable person would look at who knows nothing about medicine and be like, oh, that looks like a muscle spasm. But spasticity specifically is like a rigid, like really like strong jerky motion.
Thank you.
Of course. All right. Well, if there's no other questions, please, I'm here. Feel free to ask questions or feel free to ask me to explain something again. If not, hit me up on WhatsApp. If you want to, we can just have a call tomorrow night or tonight if you think of anything, and you want me to explain anything or run through everything. For those who don't know, Teams has been just an absolute nightmare with giving you guys access to the recordings. So I just straight started uploading them all to YouTube. There's a YouTube channel that is just literally just these videos. Hit me up on WhatsApp if you want the link, or it's probably floating around amongst the students. And this will also end up there. So, and it's every video, every recording session I've done is on there. So, all right, thanks guys. Good luck on your exams.